Okay, so for
You
5109,
saw it. Did you see that note from Shangari saying that she
yep,
might be able to dial in, but not with her video? Yeah.
yeah, she's at work. Yeah, yeah,
Yeah.
she did
Sorry.
say. Yeah.
Sorry to interrupt.
Mm. Yeah, so you've had your ISAP results so far for this unit. That's the only results that you've had. And I've just made available the formative test one video recorded feedback as well. So as I mentioned, this is basically a catch-up session for us to listen to you guys. So if there's anything specific that you want to ask. Oh, I just remembered, Joanne.
Yeah.
um,
Yeah.
you were asking about Charco's joint, and Tony, I totally forgot. I was going to ask, maybe we can ask Madeline. Madeline, do you take weight-bearing X-rays of Charco's joint?
Yes, we do. It is in our protocol that if the patient's able to weight bear and it's written on their form or there's an indication in regard to Charcot's joint, we do weight bearing images.
All right. Okay.
Mhm.
So, Joanne, there's your answer. I was going to ask a radiologist that sometimes come and teaches the undergrad, if they're still doing it. I wasn't sure because I haven't worked clinically for so long, and Tony as well. So,
Yeah.
okay. So
Well,
we still do it.
I went and did some investigation online. I don't know whether you did, Joanne, but I did find a clinical guideline, which is the international group for the diabetic foot or something similar to that. But it seemed like quite a highly regarded, reputable group of scientists and clinicians. And basically, in Precy, what they seem to be saying, and I'll forward you the guideline as well if you want. I'm not sure you'll want to read the whole bloody thing. Well, I didn't read it all, but I sort of plucked the eyes out of it. But basically, what they seem to be saying is that um, weight bearing is expected, um, but if the patient can't tolerate it, then it shouldn't be done. So, which is along the lines of what Madeline just said. If the patient can't do it, and along the lines of what you said when you in your email, if the patient can't tolerate it, then don't force them to weight bear. But what I was hoping to do is actually to find some research um, to actually validate it one way or the other, because we have to use evidence-based practice, of course, wherever possible. Um, but in this particular case, there doesn't seem to be any evidence for weight bearing versus non-weight bearing radiographs of Charcot foot. Um, the I mean, just thinking myself why that might be is because the sample size would be very small. I'm not sure how many patients you see with Charcot foot, but my recollection is there's not too many.
Yeah,
Um,
so for my practice here, our patients usually present quite late
mm,
because our hospital was just set up in this region. So I suppose when they actually see a doctor, it's already advanced disease. So my chain of thought is if it is advanced, uh, is there any value added information in the rocker bottom kind of presentation?
mm,
Yeah, I
yeah,
was just wondering, is there like for example, post-surgery, if they were really, going to do some modification, then is there any value added information?
yeah. I think
Mm.
other than clinical guidelines, which are, I guess, they're not exactly evidence-based practice. Clinical guidelines are up there, but they're more like level 4 evidence rather than level 1 or 2, because there's no randomized control trial of um, of weight bearing versus non-weight bearing radiographs. Here's Helena joining us as well. So, and of course, sample size is going to be an issue, as will, there'll probably be quite a small difference between the measurements without weight bearing versus the measurements with weight bearing. And so measuring that difference, on a large enough group of patients, particularly those patients with the rocker bottom deformity of their foot, is going to take a long time, basically, because the presentations are, there's not a lot of presentations of patients with Charcot's foot and rocker bottom deformity to actually get a large enough sample to be able to tell a difference between the measurements with weight bearing versus the measurements without weight bearing. So to try to do a sample size calculation, you might end up with somewhere of the order of several thousand patients required, split between the two arms of the study. But to find several thousand patients fitting those criteria, it'd probably have to be a multi-center trial, which is always difficult because that means that you've got to negotiate and distribute protocols, and so it'd be quite a complicated and difficult process to actually do the research. And I think that is sort of my justification for there not being any level 1 or level 2 evidence, is that the research basically hasn't been done. There is research about immobilization of patients, weight bearing versus non-weight bearing immobilization. So whether or not to actually put them in a cast while they're weight bearing, or to put them in a cast when they're not weight bearing. And that seems to show that weight bearing is better when they're being cast. Okay, not when they're being radiographed without a cast, but and I can't tell you the details of that research off the top of my head. So I mean, it would be lovely to be able to, get your teeth into that research, but I think it would be not an easy study to actually put together. I think it would be quite difficult, and it would take many years to actually collect enough data to actually be able to detect a difference and to see whether that difference was significant, basically, which is what you seek to do in research. But so that's my very long-winded and very probably indefinitive answer to the question about whether weight bearing. I mean, I would think if it just comes down to that issue. If the patient can't tolerate the weight bearing views, if
Don't
they don't,
force it.
yeah, then I think it's non-weight bearing. But that's going to be a discussion that you'd obviously have with the patient in the first instance, but also with the referring doctor, with the endocrinologist or the orthopedic surgeon, or whoever it might be that's actually requested the examination. Now, Helena's actually walked in the middle of that, so she's got no idea what the bloody hell I'm talking about. Helena. We're talking about Charcot's foot and
I
weight
figured I
bearing
sort of
versus
kicked her.
non-weight bearing views in patients that actually have a rocker bottom deformity of their foot. I think the other thing is, by the time it gets to that stage, the patient having a rocker bottom deformity, it's not a question of whether or not the patient's got Charcot's foot or not. It's just to what degree. Their deformity is actually treatable, and treatable by casting. But and again, I'm not an expert on that, but I think it's an interesting question, Joanne. I'll flick this guideline to you just in case you want to actually talk to your radiologists or orthopedic
Yeah, it's
surgeons or
just
whoever.
something very random when I read the journal. And then I was just reflecting on, our simulated weight-bearing practice.
Mm,
Because simulation is very variable. So yeah, basically if they insist on a weight-bearing, then we will, just place hand back on the patient. They ask the patient to
mm,
press down as we do the
mm,
exposure. Yeah,
yeah.
so yeah, just wondering the
Look, it's
value in
yeah,
that exposure.
yeah.
Can I
No,
just ask, do the measurements that the orthopods do on the weight bearing, because they do measurements on the lateral as well as on the DP of the foot, do they also do that same measurements on non-weight bearing? Was their preference for it to be weight bearing?
Basically, if we see the special request as weight-bearing, then we will do a simulated weight-bearing.
Okay.
If, the patient is unable to weight bear.
Okay.
So I haven't really, had the chance of having the patient to have a non-weight bear and a simulated weight bear for the orthopedic surgeons to compare.
yeah. And that article that you have to read does actually talk about the different measurements that are taken and that sort of thing, but
Okay.
don't
Yeah,
necessarily expect you to have
I
that
shared your
depth of
journal.
knowledge. Sorry.
I shared your journal with my MRI colleagues.
Yeah,
Yeah, they wanted
Talk to
it.
your MRI
Yes.
colleagues about it, and you can show them that clinical guideline because that talks about MRI as well in the clinical guideline. So it's up to date, but um, yeah, just lack of research evidence, which is something that you run into quite frequently when you're actually trying to look at clinical evidence for, various clinical protocols, which are based more around, gut instinct and clinical knowledge than an actual research evidence, hard, fast research evidence, which is ideally RCTs, and that's hard work. Yeah. So anyway, so on that note, any other questions? Probably turned you right off asking any more
I'm okay for now.
questions.
So Helena, similar like the other night, as we said, it's a catch-up session. So if you've got any questions about the ISAP cases that you've done, I've just released the formative test feedback as well, or anything about the upcoming exam and your clinical portfolio, this is the time to ask us. So any one of you guys.
Sorry, I'm just in the middle of work and I'm expecting something to come through. So if I suddenly disappear, just a heads up, it's
Okay, so
calling.
maybe you must talk first.
Sorry, but I don't have anything in particular in regards to questions. I think personally I'm plodding along okay with the content. I just want to add in, like the other night, positive feedback to the structure of the course. I really like how both of the 5108 and 5109 are set out, the amount of content that students are receiving. I just want to provide verbal feedback overall that it's enjoyable so far, and I think I'm getting my money's worth out of it, and I'm learning quite a bit in regards to image interpretation. So it's helping me formulate how I interpret images as well clinically, and I'm applying it now into practice. So it's slowly getting there. I like to see the knowledge and application. So yeah, it's going well.
Okay, so that's
Yeah.
really good when you say that you're applying it in your practice. Is it for yourself, or are you actually sharing it with your colleagues, filtering down the knowledge with your colleagues to also improve their image interpretation skills?
Yeah, so at the moment I want to get a hang of it myself to make sure I'm comfortable and confident. And then say when the requesting doctors are a bit unsure or CMOs, then I would like to go across, and if they ask me how I'm interpreting the pictures, then I've used like the ABC guideline to help me go through that process, and then I give them a good summation of it, and hopefully it helps them out, and they think it's helpful at the moment. I'm like, I hope I'm doing it right. But I always like to see what the radiologist report is afterwards to double check how I'm actually tracking along and if I actually use the right skills, and it's okay. I think
And
so far.
And if you've done RAD4502, you know how you work out your sensitivity and specificity. It's really useful to but you're going to do it in any case with a clinical portfolio to work that out, to your audit of yourself, to see where you are and how well you track with comparing your report to that of the radiologist as well. And that's really useful to know, because you can then pick up maybe the specific areas where you exceed, where you're really good, but there might be some areas where you feel, okay, I need to go back and do some more research and reading around this as well.
Oh, okay. Yeah, I'll keep that in mind. I'll have to incorporate that into my practice too. Wonderful. Thank you.
Okay. Madeline, anything from you? I think Joanne seems quite busy at the moment, if I look at her head. Madeline, anything from you?
No, very similar to Helena, similar to last semester. As I said, I've been a little bit busy this semester, so I'm nearly caught up, catching up, but otherwise tracking well. And the first ISIP cases were pretty straightforward, so not too bad.
All
Yeah,
three of you seem to do quite well with your ISAP case. Got the gist of it, and I mean, obviously there's going to be some gaps and some disagreement between me doing the marking, I guess, and you guys doing the report. But hopefully that agreement was actually minutely small. Disagreement rather was minutely small. For the most part, you did very well, and hopefully learned something along the way about classifications of fracture types and those sorts of things, which are useful information. Sometimes we think, oh gosh, it's so academic. Why do we actually need to know about, in particular those classifications, the log Hansen classification of ankle fractures and those sorts of things. Well, I think what that does is actually gives you an insight into where fractures occur, and if you can actually glean the mechanism of injury from the patient, and often that's actually difficult to do to get that information, then it'll give you some indication when you put the image up on your monitor where to look and how hard to look. And once you've actually seen something, where else might you look? It's interesting that more students than I thought actually missed the fracture of the posterior malleolus. I don't know whether that's true of any of you three, and you don't have to say, but I was kind of surprised that people were missing that fracture, because it's one not to miss. And it does occur. Okay, it's relatively rare as an isolated fracture, but when you've actually got a patient that's got a pronation, external rotation, injury of their ankle, then that's certainly on the cards, that they're actually going to have a fracture of the posterior malleolus, and it should be somewhere that you actually deliberately cast your eyes to that and have a close look. And I think this is the benefit of actually thinking about those classifications. And there's a large range of orthopedic classifications for different fractures in different regions of the body. I don't expect that what you do is you actually learn all those classifications in depth. But if you have them in the back of your mind and you're thinking about them, then it makes you more accurate with your interpretation. And, certainly that's what we're about, isn't it? Actually trying to be as accurate as possible, get the best outcomes for the patient. So anyway, that's my little soapbox about the ISAP case. In particular, that posterior tibial lip, posterior malleolus fracture. Look for it. When I was a young radiographer in the old days, we used to do 4 routine views of the ankle always. That was the way that I trained. So it was always to do an AP and a medial oblique, a lateral, and then an over-rotated lateral. What's sometimes referred to and has been referred to in the literature as a poor lateral, because you over-rotate the patient so that you actually see that posterior tibial lip. And so I have a few cases in my library of fractures, of isolated fractures of the posterior tibial lip, which are not seen in the other three views. Not visible in the other three views, but you do that over-rotated view, which is in the literature, and bingo, patient's actually got a fracture. The hint towards that is also, however, the fact that they're positive for the Ottawa ankle rules. So they can't weight bear, even though you've actually performed three views and you can't see a fracture. Patient's still got, good clinical indications that there's a fracture there. I can't see a fracture. What's going on? Is this patient a sook, or, is there something going on there that I'm missing? Well, it might be that the patient's got a fracture of the posterior tibial lip. And so you go and you do that fourth view. And it's, this is the way having that information in your brain makes you a sharper radiographer, a sharper ED radiographer, because you're thinking about where fractures might occur. You're not just doing the routine views and flicking them off onto the packs and bye-bye, that's it. You're thinking about what's going on clinically. And yeah, it's a, I mean, I've often thought I should write an article about pattern recognition other than just recognizing patterns on images, because it's a pattern. There's a pattern there of the patient's presentation, how they've injured their ankle, where they're sore on physical examination, what the literature says, and then looking at the image from that perspective. These things don't occur randomly. Fractures don't occur randomly. They have patterns. They have, unless it's extreme force, and then of course you can get fractures anywhere, and you do. But with the average sort of patient that comes through the ED, there are some conditions, as you well know, that you can almost predict where the fracture is and what the fracture is going to look like as the patient walks in the door, because they've got that look about them. Dislocated shoulder is the obvious one. I saw one on the weekend on TV, because you see it on the footy. Some guy's gone down and he's gone down on his elbow. And then he hops up and he's in a lot of pain, and his shoulder's flattened on the outside, and his acromion process is sort of sticking out, looking, very obvious. And you think, okay, that guy's dislocated his shoulder. I don't need, an X-ray to tell me that. Obviously, you'd still need to radiograph the patient because you don't know whether they've got a fracture. But, the point is there are patterns to these things, and it's learning about those patterns from the time that the patient actually has the injury through to the time that you put the radiograph up on the viewer, that you can sort of predict. There's a line, a process. So yeah, I guess in many ways I'd like you guys with these ISAP cases to think about those patterns, to actually try to understand the relationship between the clinical examination and the mechanism of injury right at the outset, through to the appearance on the radiograph and the treatment as well, to some extent. Well, that they're not necessarily going to be doing the treatment. It's good if you know what the repercussions are going to be. So anyway, I'll shut up.
Yeah, Tony has spoken quite a lot.
Yeah, I have tonight, and I know you have an agenda.
No, I don't have an agenda. I'm waiting for them to ask us questions. Just to say that you will have another formative test as well in week 12. And that's the two combined will, so the first one covers the materials that we've done up till now, and then the next one will the rest of the materials. And so it will give you a fair idea of what to expect in the exam. And then, of course, your clinical portfolio. I just wanted to ask, are you okay with all the body regions that you need to get for a 5109? Because you've got to get the thoracic and lumbar spine and then the pelvis and lower limbs. Are you okay with all of that? You both say yes. I see Helena had to leave. I just saw quickly disappearing as well. So she said a piece.
Can I ask a quick question? Majority of the obviously spinal imaging, similar to C-spine, that would have been in the upper limb unit last semester,
Hmm.
is all CT'd. We do a few X-rays of like the TNL spine, but they're usually stability post identifying a fracture.
Okay.
Are we still able to use those? Like they're not necessarily initial assessment though.
Yeah, what you could also try and do, because remember, you don't have to be the one who x-rayed the patient. You can maybe go onto your system and see whether you can find retrospective cases that you can include. So that's one example. But I also think that if that's what you're seeing currently, then you should be able to use it. I don't know what you think, Tony.
Yeah, I agree. That would be one solution, is to actually go and, retrospectively collect cases, Madeline. But I think,
I had a look at our packs for the last month or so. And yeah, that's for the
yeah,
most part pretty well all just stability after they've identified a fracture, following like a trauma CT scan.
So really the CT becomes the follow-up imaging. Is that right?
Or do
Is
they
So
that
go
they
my
straight
understanding? It's not the initial imaging.
so they go straight to CT and then
They go
from
straight
CT,
straight to CT, a referral straight to CT from ED.
yeah, yeah, like a head
Not
C-spine,
necessarily
chest
best,
abdo-pelvis kind of thing. Um,
not necessarily best practice, but it's hard to convince them otherwise.
Absolutely it is.
Yeah, um, but I guess, yeah.
Could you
I
look
mean,
further
really,
back?
the CT should be the confirmation. Yeah, are you talking spine or are you talking
Yeah,
extremity?
spine. Yeah,
Spine.
no. Like TNL spine, we don't do a lot of those through the emergency department.
Okay.
Yeah,
Um,
yeah. No, it's
but like
understandable.
as I said, I sort of searched the last month. I can expand that and
Yeah,
see if
look
there
further
are
back and
a
see
few more.
maybe if you can, even if you can just find one or two for those body regions, because you remember you've only got 25 cases to collect and it has
Yeah.
to include all the body regions as well. Yeah. So if you, especially the ones that you struggle with, if you can have two, that's fine. Yeah.
Mhm.
Hmm.
Okay.
And you, Joanne, are you okay with the body regions for 5109?
I'm okay. I'm just wondering, right? Because we recently had this AI software
Uh-huh.
installed. So it's very curious of me to, go and just take a look at how the AI is working after I've done the evaluation. I don't know how it translate to practice. I mean,
Well,
I'm
it's
not going to record the AI
yeah.
results, but I'm just very curious how it will look.
No, it's quite interesting. I've just, my fourth years, they've just written an exam for me that included some questions around AI because they're in clinical placement and they see what's happening. So some of the AI capabilities is actually installed into machines now. And the main thing is with AI, so you've got, when you look at images, you've got what they call an absolute threshold where the human actually can't see beyond that. And AI can actually pick up on the very subtle stuff. But you can't rely on AI. And that is the key thing that comes through even the radiologists. None of the radiologists will sign off just on the AI report because they take the responsibility for the report. So what the AI actually is, it's an additional resource. So it's like an extra pair of eyes, but it's not the definitive resource. It's not the one that should write the report. But AI can pick up subtle stuff that you don't actually pick up. And also some of the AI, they can almost do automatic windowing and stuff like that to improve your image. So there's actually quite, especially with our imaging, there's a lot of advantages to AI coming out. But in terms of interpretation, and AI has been very useful with the chest because the chest is so difficult to interpret. Very useful in terms of nodules and those kind of things. But AI is also very dependent on large data sets and accurate data sets. And that's why the radiologist can't just say, okay, this is what AI says, I'm going to include it in my report, because it depends what data sets the AI is reading it from, because it's human stuff that's been put up. They're not pulling, AI is not pulling it out of their own head. They basically text matching, as I say. It's almost like with your assignment where you get a Turnitin similarity index. It's actually text matching, more or less, and with images as well. So very much dependent on large data sets and also accurate data sets. So it's a useful adjunct to radiology, but it's definitely not a definitive, but definitely it can provide improved image interpretation, especially around things like those subtle stuff that can be missed as well.
Yeah, I'm quite cognizant of the struggle to learn the stage part of learning, because I was just, having this induction into AI now, and then in education. So we have this saying that, the learner has to struggle to do whatever learning. So definitely I will try to do it myself first. But I think the AI part is very interesting to see how much I've missed. And after that, correlate with the radiologist report as well.
Yeah. Initially, the radiologists were not very keen on AI and interpreting anything that had to do with what their work was. But they've now already recognized, especially if the radiologists that took it on board as an additional resource and started, putting together, because there's been a lot of multi-center research around specific pathologies that can be picked up. And I think the breast is another one where AI is really very good. So it has been demonstrated as a really good additional resource, but it is not the final resource. And you still need the human eye to look and also to check that the AI actually correctly interpret what it needed to interpret. So you can't take AI at face value, but AI can really improve things like reporting. I think some people are asking the question, so doesn't it make radiographers redundant in terms of image interpretation? Because you are an additional resource as well for the EDE and also for radiologists as well. And I still think that human eye and that human, because AI is not there when you x-ray the patient. AI is not there when you, like Tony said, knowing the mechanism of injury, that whole process, AI is not there to pick all of that up. So that human intervention is still really important. But AI, I think, I was actually quite against AI as an academic. I just saw it's plagiarism, The students are just going to get AI to write their reports for them. And in the end, our university has really forced us to accept then they took a while to adopt it, but they realized you can't ignore it anymore. So we are very much engaging with AI, and we've got at the moment what they call programmatic assessment and artificial intelligence review. So in terms of how we deliver our courses, our learning outcomes, our assessments, so all of that is now under review, especially since AI came along. Yeah. So I.
Shangari has joined us too.
Oh, okay. Yeah.
Hi,
All right.
Shangari.
Hi, Shangari.
Is your microphone working? I know your video is not working, but is your microphone working? You can always use the chat down the bottom of the screen if your microphone
Yeah, I
is
can
not
see
working.
she's on.
Hi, I'm at work and I'll try to be here as much as I can. So, okay. Thanks, Shangari.
Okay,
Well,
so
I'm
I
assuming
thought,
she can hear us.
yeah, I think so. I think so. Can I maybe just ask any one of you, have you had any experiences? Now, Joanne has mentioned about AI, but the other two, have you had any experiences with AI being used?
We haven't had any like specific use of AI yet, but because there's talks of getting a new CT machine, everyone's talking about the new models. Are they going to be AI integrated and using that? But apart from that, we haven't actually used it in our reporting stages per se just yet. I think a lot of the RADs that I've spoken to are a bit hesitant. Like, is it really going to be that great? Not just of, say, job insecurity, but the accuracy of detecting pathology. So it's still, I think, taking a bit of time for even people to accept it. So in development stages essentially at the moment.
Okay.
Yeah, I think Imelda made a good point earlier about the fact that AI can't factor in some things that like human intervention can, like getting information from the patient, actually talking to the patient, finding out where they're sore, how did they injure themselves, and then doing a bit of a physical examination yourself. And I certainly don't object to radiographers using their skills and knowledge to, and their fingers and their eyes to actually find out information from the patient that may then inform how they go about performing the examination, but B, how they interpret the radiograph. And it's those things that Imelda mentioned, mechanism of injury and the patient presentation, signs and symptoms that aren't factored into the AI algorithm at this stage. AI is purely scanning images to detect differences to the normal. And the other thing that I think possibly, no, I don't know enough myself, possibly confounds AI is anomalies, anatomical variants, and probably also conditions that are rare, relatively rare, and can be therefore missed on AI. Certainly, from what I've seen on of images that have used AI, there's mistakes made. AI makes mistakes, but radiologists make mistakes too. So do radiographers. But I always think the more eyes that look at an image, the better. And so, if the ED physio is going to look at the image, then cool. But they'll see it after you do. If the ED physician is actually, if the junior medical officer, if they're orthopedics, if everybody looks at the image, then surely we've got a better chance of actually detecting abnormalities, particularly subtle changes, and therefore making sure that the patient gets the treatment they deserve. Yeah, so AI seems to be, as Helena said, at this stage, it's sort of a little, or was that you, Joanne? It's a little bit underdeveloped, but it's obviously going to improve very rapidly. And you guys have to factor it in to where you sit in relation to AI. Same as you have to factor in where you sit in relation to other members of the multidisciplinary team. And I think there needs to be some thinking around that, about how you integrate with the team and how you work together and what have you, without professional boundaries getting too messy. There's risks involved in messy professional boundaries, which I won't go into because that's another soapbox that I like. But yeah, so factor it in, think about it.
I remember the first workshop that I attended at university about AI, and the facilitator said, "Okay, let's put a question to AI and see what it's going to spit out." And the question was, "Who is the first female president of the United States of America?" And the answer was Hillary Clinton, because it picked up the word president from vice president. So at the time, she was a vice president, but she wasn't president. So he picked the AI actually picked up, and that's why I say it's like text matching. But now it's much better. Now the more data it gets, the more improved it gets. But it just shows, and that's why I say also to the students in the university, they say students need to acknowledge if they've used AI. What have they used it for? What were their search terms? And but they still need to write their own work. You can't trust what AI do. I did another sort of a class activity, and one of the key things that I gave them a scenario and they use AI, but AI was using terminology that was old. It actually, and they asked a further question under AI, and the response was something like, "Oh, oh, I've only got data from 10 years and beyond," something like that. So it didn't have recent data, but some of the terminology was really archaic terminology as well. So it really depends on the data set that AI can work from. But I do think in terms of the equipment, and especially if you go to conferences now, you would see there's a lot of presentations on AI and on equipment and what AI can do. I think there's a lot of money being invested into that. Things like positioning and making, with some of the machines, you just press one button and AI does the rest with the patient. You don't have to really position the patient anymore. So yeah, so I think there's a lot of investment in terms of AI, but and you have to acknowledge that and also get used to it if you have that equipment. And one shouldn't feel threatened by something is unknown. The best way is to actually know as much about it, so that you can understand it first and then incorporate it in the best way you can. Okay, so I know with Shangari, if you've got any question, do you maybe want to type it for us in the chat box? Because I think we have with the two Helena, I think had to leave us again. With Madeline, Joanne, we've asked already, if they've got any questions around especially the clinical portfolio for RAD5109, and also the ISAP case that you've received feedback from, and I've posted feedback on the formative test. Is there anything that you want to put in the chat box, Shangari?
I did ask her that question directly via the
Oh,
chat box, and she
okay.
hasn't come back
Okay.
with anything at this point. Now, that might mean that she's not at a
Not at the
computer.
computer. Yeah. Okay. But we're
Um,
recording it anyway, so I'll post the recording afterwards.
mhm.
Yeah.
Oh, hang on. Shangari's written back. No questions at the moment, thanks.
Okay. All right, so Shangari, you've missed the majority of what we've discussed, but as I said, I will be posting the recording there. It's been more of a general discussion, starting off with Charco's foot and all the other things as well. But I think if I can just go around, Madeline, is there anything else that you maybe want to mention, or you're happy so far?
No, I think I'm pretty happy so far, relatively up to date and know what we need to do.
All right, awesome. And Joanne, you okay from here on?
Yes, very happy.
All right.
Very, very
Okay.
happy. Like that.
Yeah.
Like the
Now,
adjective.
yeah, Elena, I don't know whether I think she's just off.
Oh,
Oh, there's Elena.
come-
Hopping on and off.
Sorry.
You're like a little bunny on and off.
Sorry, I think I have to go. I'm in the middle of doing a CT scan. So
Okay.
if there's anything,
Okay.
I'll just watch back on the recording. I'll email you guys. Thank you so much for your time again.
Okay.
And good luck with everything else. Thank you.
All right.
Okay.
Thank you. Bye.
Bye.
Okay, so I don't think there's anything else that's the two. I know from myself that I would like to mention. Just to let you know that you will have a couple of days off starting Friday for a week, because it will be mid-semester break, so you can do all your catch-ups then. For especially for, I can see you guys are extremely busy at work. So that will give you a bit of a breather, and we're almost getting to the end of it now, so it's not going to be too long. And then you have another break before we actually have the exam and then the clinical portfolio. But as always, if you've got any questions for us, just feel free to email us and copy both of us in, so that we can respond. Sometimes Tony's better to respond to something, and maybe sometimes it's me, but it's helpful if you copy both of us in. Okay, Tony, I don't know if you've got anything else to say.
No, I think I said quite enough tonight, Imelda.
I just want to
think
keep you
okay.
for 1 minute, and this time it's going to be 1 minute, just an update on something else again.
All right.
But
Yeah,
yeah,
there's a lot going on at the moment.
yeah, just a short update. It was actually a question that you had asked me the last time when we spoke, so I've got some feedback on that. All right, Madeline and Joanne and Helena and Shankari, thank you so much for joining us, and all the best. And I hope you can have a bit of a break next week, not just catching up as well. All right. Okay. Bye.
Thank you.
Bye.
Bye.
Bye. Yeah, Tony, just feedback. You remember you asked when I spoke about the master's program whether the students could exit with a dip, and I did email Tammy, who's
All right, your recording's still on.
oh yeah, let me quickly stop